So good evening and thank you everyone for joining us on our East Sussex Eye Group, our latest webinar. Thank you for those who are already members, and if it's your first time, thank you for joining us. This webinar is being recorded and will be available to watch again on our YouTube channel, the East Sussex Eye Group. There is one CET point available today if you're watching live, and that's for optometrists and dispensing opticians. And I will send out the certificates in due course. I do have 10 days to send the certificates out. And as it's the Eastbourne Air display this weekend, I won't be on my computer. So it's probably going to be next week I'll send the certificates out. So the lecture will run for approximately 45 minutes with about 15 minutes at the end for questions. So if you would like to ask a question to our speaker, please type in the bottom of your screen. There's a Q&A box, type your questions in there. And at the end of the webinar, I will then pose the questions to our speaker tonight. So I would like to welcome Mr. Kashif Qureshi. He's an ophthalmic consultant surgeon at East Sussex Healthcare Trust, specialising in the management of complex medical retinal disorders. He performs intravitreal anti-VEGF injections, steroid implants, anterior and posterior segment laser treatments, as well as high volume cataract surgeries. For the past 2.5 years, he's been the clinical lead for East Sussex NHS Trust and been doing an amazing job. He's also a member of the Professional Standards Committee for the Royal College of Ophthalmologists. So tonight, I'd like to hand over to Mr. Qureshi, and thank you again for joining us tonight. Thank you.
Thanks, Ian. So what I'm going to do is just share my screen. Let me see, Keynote, share. Now I apologize because I'm using my wife's laptop and I'm trying to work out how this works. Why is it not doing that? Open system parameter, security and privacy to grant. Sorry, Mike. Oh, I never use a Mac when you need to be using something else. Security and privacy. Yes. Okay. Sorry. I need to allow Zoom. Yeah, to record content. Right. Okay, let me try that again. I do apologize about this. This is, there we go. That seems to be right. Hopefully you can all see my screen now. I'm just going to maximize that.
We can all see that, Cash. We can see that great.
Fabulous. Sorry about this. My trusty Windows PC has failed and it made me look green on the camera, which some people say I do look a bit green, but I generally don't. So tonight, what I'm going to talk about are what people in our area call minor eye conditions, but they're not really. But really, it's about primary care ophthalmology and a common range of conditions that, as optometrists, you'll probably see in the community and often be able to manage yourselves. And the direction of travel with ophthalmology in the NHS is that more and more of this care will be delivered by optometrists in the community, as it should be really, because hospitalized services really can't manage the levels and numbers of patients that are being required. And, you know, there are often other things that we can do. And this is stuff that's well within your skill set. And I'm privileged also to work alongside both in the hospital eye service, some excellent optometrists who do primary care clinics, as well as lasers and other interventions, and also in the community. I work in acute primary care ophthalmology service in West Kent and East Kent, and work alongside independent optometrists who are managing many of these conditions on their own. So I'll stop gabbling and I'll carry on. So the first problems to talk about are corneal problems. And these are surprisingly common. The big ones to worry about really are corneal ulcers. And corneal ulcers, as you probably all know, can be bacterial, can be viral, fungal, or sometimes even inflammatory. Important to take a good history from these patients to try and determine what the etiology might come from. Generally speaking, you'll see a sort of circular abscess in the cornea and often a hypopion. The eyes will be intensely red, very, very painful and irritable, with a lot of photophobia and tearing as well. Risk factors for these diseases, the biggest risk factor by far is contact lens wear. Ocular surface disease is a significant risk factor, as well as eyelid disease, and immunosuppressive disorders tend to be, or being on immunosuppression tends to be a risk factor. There are systemic inflammatory diseases, of course, like rheumatoid arthritis that can cause corneal ulceration and melting. And so it's important to take a sort of good history to try and establish what the etiology is. Importantly, for your perspective, it's very important to manage or refer these things on the same day of when you see them. So these people should be seen by whoever in the appropriate primary eye care service straight away, so that they can be given empirical investigations and empirical treatment rather, to try and start the management for these patients. So if you've got a patient with you, if they've got their contact lens case, or if they can get it from home, it's often worth asking for them to take it to the hospital with them, or whoever is looking after the patient, for the contact lens case to be sent off for culture as well. In the hospital eye service or in other services that manage these patients, we'll also generally tend to do a corneal scrape. So with topical anesthetic, we will scrape off with the bevel of a needle the base of the corneal ulcer, and then plate it off into bacterial media, agar plates or broth liquids, and send off to microbiology for investigation. Generally, we start these patients empirically on a monotherapy, such as with a quinolone and cyclopegia, with cyclopentalate 1% twice a day, and that helps relieve the pain slightly. The quinolone should be given hourly, day and night, for sort of 24 to 48 hours to ensure that the ulcer is sterile, really. Sometimes we give dual therapy, which will be quinolone like ciprofloxacin or ofloxacin, and a cephalosporin like cefuroxime drops, and cyclopegia drops as well. What's going on now? That's it, right. So I'm sorry about this. This is where Macs really do my head in. Right, okay, there we are. So what's the difference between an infective lesion and a sterile lesion? Sterile microbial ulcers tend to be smaller, they tend to be more peripheral, you tend to have very minimal epithelial damage, and there tends to be very little or no mucus discharge. There's often a lot less pain. It is often a bit painful, a bit teary, but not nearly as much pain as with the infective ulcers. There's often almost no anterior chamber reaction, and the eyelids often are completely uninvolved, whereas an infectious ulcer tends to be larger, more than 1 millimeter in size, more central in location. There's often quite significant epithelial defect, which you can obviously pick up using fluorescein staining, and there's quite significant mucopurulent discharge. The eyes tend to be very, very painful and photophobic, and quite often there's an anterior chamber reaction, so you see cells floating around in the anterior chamber, and quite often the eyelids themselves are quite red and puffy and uncomfortable. So sterile ulcers can be caused by marginal keratitis, which is often associated with blepharoconjunctivitis, quite often with no contact lens wear. It's a condition which is mediated by staphylococcal hypersensitivity. So staphylococcal bacteria that live on the ocular surface cause a hypersensitivity reaction in the cornea. And this causes ulcers, which can appear parallel to the limbus, as in this nice photograph. There's often a millimeter or so of clear cornea between the ulcer and the limbus. And in contact lens related peripheral ulcers, you can get staph colonization of contact lenses. So people with contact lens wear can get similar presentation due to staph colonization, and they get these very small ulcers in the periphery, often with a gap between the ulcer and the limbus. Very uncommon to get anterior chamber reactivity, and often no symptoms associated with it. They're just often sometimes aware or aware of vague irritation to their eye. So how to manage marginal keratitis would be to use topical antibiotics, and when the acute phase is better, consider using steroids. So in the past, in the good old days, we used to use sort of Maxitrol or Predsoln. If you're being cautious, you would tend to try and treat it with an antibiotic to sterility, so for about 24 hours. And then when you next see them, given a weak steroid like Softacor or FML, and it usually resolves pretty quickly. Contact lens related peripheral ulcers, obviously stop wearing the lenses is the key thing. And consider giving a quinolone topical antibiotic like ofloxacin until the epithelial defect heals. Adenovirus keratoconjunctivitis, so very, very common, amazingly well underdiagnosed in the community, and Americans call pink eye, and you can see in the photograph on my left and your right, or your left maybe, the eye does look rather pink, and a bit injected and quite chemotic, lots of chemosis. Sometimes these patients get epithelial precipitates, which you can see in the other photograph in the cornea. The thing about epidemic keratoconjunctivitis that's important, and it's quite fashionable now with COVID, is that it's incredibly contagious. So one needs to be aware, if you've got a patient with this, that they must quarantine themselves away from other people, because they can infect everyone around them. When I used to give this talk in the past, we used to sort of laugh at the concept of quarantine, and we also used to laugh at the concept of, in America, they used to give these people what was called a staff furlough, which was a word we'd never heard of before. And the staff furlough, they're sent home until they're better, and then they come back to work on sort of paid leave. Now we all know what a furlough is, rather tragically. It applies to this particular condition because it's so contagious. So someone works in an office or a hospital or any work of, place of work, they can infect all their colleagues around them, because it can infect the GI tract and the upper respiratory tract. So you can touch, cough on, sneeze, handle food, and someone will catch this infection. It tends to cause a lot of redness, itchiness, irritation, often photophobia and very watering eyes. Sometimes people describe it as a foreign body sensation and blurry vision, and often there is lid swelling. When you examine them, you can see follicles, so follicular conjunctivitis. If there is discharge, it tends to be clear or yellowish or mucousy. And as I said on that previous lecture, you can get epithelial keratitis. For the more medically minded of us, if you palpate their lymph nodes underneath, right in front of their ears or underneath their jaw, they can have a lymphadenopathy, particularly in front of their ears. The preauricular lymph nodes tend to get inflamed. They can have a fever, a headache, and more than 50% of these patients, the other eye tends to get affected. But from your perspective in optometry practice, if you see someone who comes in with a very red, irritable, itchy eye like this, and it's worth asking them if they've had a cough, cold, or a sore throat recently. And if they have a strong suspicion that this is an epidemic keratoconjunctivitis, and in which case, put your face mask on, wear your gloves, stay well away from the patient, and and sort of hazmat down the slit lamp after the patient's gone to before the next patient comes in. So these are pictures of very chemotic adenovirus conjunctivitis on one side, and the other side has got a lovely picture of follicles. And the follicles are these whitish, almost like grains of rice that you can see on the tarsal conjunctiva, and you can see that in the upper or the lower lid. Sometimes you get pseudomembranes as well, so these sort of plaques of whitish material that's stuck to the inside of the eyelid. And if they are pseudomembranes, they can get peeled off, or you can peel them off with a pair of forceps, which can be quite painful sometimes, but it helps. Sometimes the condition resolves slightly more quickly. So next, with regards to foreign body corneas, corneal foreign bodies. Now, these are incredibly common. Usually they're young men who angle grinding, and they always say they're wearing goggles and it went in through the side. Amazing how many times you hear that. They are very easy to remove, very easy to sort out, and can be removed in primary care very, very easily. When you shouldn't be removing a foreign body, which is what someone asked me, and probably why I put this slide like this, is if you've got other problems with the eye. So if you've got a high femur, you need to think about this. So this is a traumatic injury, and that could be blunt or penetrating trauma. If there's a diffuse corneal opacity, so there's a possibility of there being significant infection. If there's a laceration, a history of a laceration of the cornea or the sclera, because then the eye will be soft. If the pupil is dilated or abnormally shaped, I would be a bit cautious, because that also indicates there might be a penetrating injury, but it hasn't been picked up, or indeed a shallow anterior chamber, particularly compared to the other side. How do you do it? You use a topical anesthetic like proximeticaine or binoxynate or tetracaine, 25 gauge needle. Make sure before you do anything that there's no perforation of the eye with 2% fluorescein or a fluorette. Make sure that the Seidel sign is negative. So you bend the needle with the bevel facing you of the needle, and you gently dig underneath the foreign body with the edge of the needle. And at the end of the procedure, you recheck with Seidel sign. There's a YouTube video here, and I'll attempt to see if I can get it to work. And then hang on, I have to, hang on 1 second. God. Technical hitches. Right, let me new share. There. Share. I have to apologize for this weird American music. So you can see them with the bevel facing you, the tip of the needle, sort of digging at it, flicking it up, and then there it goes, it's off. As easy as that. Let me go back to sharing my talk.
Hi, I'm Nick Barnes. Welcome to the workshop. We're working on a set of puppets for Life of Pi.
Nope. Oh, what's happened to my talk? Great. Oh, there we are. I'm back. Hopefully you can see that. So that is removing a foreign body. So next, chalazions. Chalazions are incredibly common. I'm sure you've seen them all in your practice many, many times. And what they are is they're incredibly misunderstood by particularly GPs. What they are lipogranulomas of the meibomian glands, and they're caused by obstruction of the meibomian glands in the tarsal plates. So you get retained secretions that build up within the meibomian glands and then cause them this big lump, which is often filled with waxy, oily material. And they can be made better in the main part by using regular massage and using a hot compress on the eye first, and then massage the lump. And often that helps melt the waxy material and then express it through the meibomian gland orifices, and the stuff comes out. If you get them in frequently in the same place, one has to be a little bit careful and think about rare things like sebaceous cell carcinomas, but that's pretty rare. So as I said, managing these things, if they're small and asymptomatic, you can leave them alone, and often they're not going to cause the patient any problem. If they're a bit larger, initially, it's worth trying using a hot compress. And best thing really is to buy something like an eye bag, or ask the patient to buy an eye bag, which they can microwave and leave on the eye, because the length of time on the eye for about 5 minutes means that it allows time for the wax to sort of melt inside that lump, and then massage the lump with a fingertip, fairly firmly actually, and occasionally stuff actually pops out. I mean, at the slit lamp, I often squeeze it, and you can see stuff sort of toothpasting out through the meibomian gland orifices, not with necessarily large chalazion, but often inspissated glands where they're blocked up, or there's a small chalazion. Sometimes you can do that. Antibiotic drops, you can use chloramphenicol or azithromycin sometimes, which helps to reduce the bacterial load, and certainly in the case of azithromycin helps modulate the ocular surface sort of immunology, and helps settle it down. But if they've been there for about 3 or 4 months and they're not going away, then one needs to consider incision and curettage, which is obviously injecting with local anesthetic, flipping the eyelid inside out, making a cut on the tarsal plate, and scooping out all the stuff inside. There are some people who consider doing steroid injections, but I must say I've probably done this about once in my career. It does work, but it's not the nicest thing in the world to do. And of course, they can come back. There are newer treatments that are available. I'm not much of an expert on, but things like IPL, which works, and even in an acute chalazion, IPL, which is pulse laser light therapy, can help to clear chalasia, small chalasia. But if they're very hard and waxy, then they probably will need incision and curettage. So there's a nice picture of a chalazion. A hordeolum was an inflamed oil gland, which is, where people get a bit confused about terminology. If it's a meibomian gland inflammation, then it's an internal hordeolum, and you get purulent material released from the inner conjunctival surface of the eyelid, and it's generally caused by staph overgrowth. An external hordeolum is where the gland of Zeisel mole gets inflamed, and you get the purulent material released from the external outer lash line of the eyelid. So that's an internal hordeolum. Blepharitis, which is the kind of precursor for this condition, incredibly common inflammatory condition affecting the eyelids, causing discomfort, irritation, the eye often to be a bit red and sore and irritable. It's incredibly underdiagnosed, particularly by general practice. If it's anterior blepharitis, it's caused by bacteria like Staphylococcus, or a seborrheic disorder, so disorder of the sebaceous glands. Posterior blepharitis, or meibomian gland dysfunction, is caused by breakdown of meibomian lipids, and it causes abnormal tear film and abnormal secretions on the eyelid. It's typically bilateral and chronic. Patients with staphylococcal disease tend to have dry eyes in about 50% of those patients. Seborrheic type have about 25 to 40% of them have dry eyes. The posterior type is the leading cause of dry eye, or one of the leading causes of dry eyes. And often, if they've got collarettes around the lashes, they can be related to Demodex mite infestations. Posterior blepharitis is commonly associated with seborrheic skin conditions, such as ocular rosacea, which is also very diagnosed. And ocular rosacea, of course, is also something that can be managed by IPL laser for the skin. So that can also help mediate things. Long-term contact lens wear can also be a factor in developing blepharitis. So signs of blepharitis. So anterior blepharitis tend to get lid margin swelling or redness, crusting of the anterior lid margin with scales at the base of lashes. Often patients have recurrent styes or meibomian, internal hordeolums. Conjunctival hyperemia. So the conjunctiva often appears a bit red and irritable. And if you look at the lash, you can see Demodex causing collarettes further up the lashes rather than at the base of the lash. If you look at the cornea, often they've got secondary punctate epithelial erosions, marginal keratitis, sometimes corneal pannus and neovascularization in quite chronic versions of the disease. Posterior blepharitis tends to be causing thick secretions from the meibomian gland orifices, which causes inspissated glands. Inspissated means blocked. So the meibomian gland orifices, when you look at them, are blocked with this sort of thick toothpastey-like material. And as I say, if you squeeze them gently, obviously, because it causes a bit of discomfort, this toothpastey, waxy stuff actually comes out of the orifice with a very bit of gentle pressure. When you look at the tear meniscus in these patients with posterior blepharitis, they've often got this sort of foamy material within the tear meniscus. They've often got chalasia. And as I said, plugging of orifices with these lipid secretions. Often they've got dry eye as well, and secondary corneal signs like epithelial erosions. So managing blepharitis, so lid hygiene, using, to try and wipe the bacteria, excess oil and deposits away. Using warm, wet compresses can help if you've got sort of Demodex or anterior staphylococcal blepharitis, to loosen the collarettes and the crusts in the anterior blepharitis, and a dry, warm compress to help melt the meibomian secretions in posterior blepharitis, which is what the eye bag does. So it heats it to about 40 degrees centigrade for over 5 minutes on the eye, and that helps that melt the wax. Pharmacologically, blepharitis can be managed. The staphylococcal and seborrheic types may benefit from topical antibiotics to reduce the bacterial load to an extent. And posterior blepharitis sometimes benefit from systemic antibiotics like doxycycline, tetracycline, or azithromycin. And sometimes these can be given for prolonged courses over a number of weeks, or more recently I've found from optometry colleagues actually who've advised to give short pulses of high-ish dose oral azithromycin, 3 days on, 3 days off for a couple of weeks, and that helps to settle things down. Herpes keratitis, very common condition caused by the herpes simplex virus, which nearly all human beings carry. 99% of human beings carry the virus in their body, and it lives in the nerve root ganglions, and it becomes infected when, or comes out causing an infection when people are immunosuppressed or run down. So in this picture, you've got a blepharoconjunctivitis with lid vesicles. Corneal involvement actually in these sort of circumstances is quite rare. So don't worry if you see people who've got lid vesicles. It doesn't mean that it's going to spread onto the cornea. Often we get referrals, particularly from pediatrics, because kids have got vesicles around their eye and they're worried that it's going to go in their eye. That's not how herpes simplex infects tissue, because it, as you know, it infects along the nerve roots. Epithelial keratitis, so the classical dendritic ulcers, are like in this photograph. It's got lovely pictures of dendrites, quite a lot of them actually. They tend to cause a foreign body sensation. So people describe it almost like a piece of glass in the eye. It's very sharp and irritable, often very photophobic and red. Vision is blurry. When you examine the patient, crucially, before you put topical anesthetics in, check the corneal sensation with a little wick of something, tissue paper or something. Ask the patient to look to one side and just rub the cornea gently and see whether the corneal sensation is intact. If it's not intact, then it's could be epithelial keratitis. Disciform keratitis, epithelial keratitis, managing this, if you are a prescriber, is to give topical antiviral like Vergan or Gangcyclovir, or used to be acyclovir, which was Zovirax, but I think that's gone off the market now, 5 times a day, and it tends to take about 2 weeks to work. So there's no point in starting the patient on the treatment and seeing them again in 2 or 3 days time, because it won't have got better by then. You need to give it about at least a week, but probably about 2 weeks to have any benefit. Disciform keratitis. So this is a sort of secondary problem with herpes simplex patients. And it's an endothelial keratitis with circular areas of endotheliitis as a consequence of someone who's had herpes simplex keratitis in the past. It often causes corneal scarring, as you can see in this photograph. I had a consultant at the beginning of my career who used to describe it like a battlefield of dead soldiers, and suddenly your army, your immune system, deciding to wake up and stab all the dead corpses on the surface of the eye. And that's what the immune system is doing to the fragments of virus in disciform keratitis. So disciform keratitis is managed actually with steroid drops, but in order to ensure we don't provoke a recurrence of the active herpetic form, we tend to cover that with topical antivirals at the same time. Often oral antivirals can be given for these patients, and it's worth, particularly in patients who've had this recurrence, for them having a low dose sort of oral prophylaxis with oral acyclovir for a period of about a year, and that tends to reduce the recurrence of this condition by about 50%. So if patients haven't got any other medical problems, it's very well worth prescribing that, particularly if they've got no renal impairment, because acyclovir can affect kidneys sometimes. So management, I think, as I said, topical antivirals, 10 to 14 days. Apparently oral antivirals are as effective as topical antivirals, but without the corneal toxicity. So you might want to give, instead of giving ointment, you might want to actually give them oral acyclovir, or ask the GP to prescribe oral acyclovir in a treatment dose for that period of time. Steroid drops in disciform keratitis, as I've said, to start with, and antiviral topically and or orally afterwards. Steroid drops can be tapered afterwards, and oral acyclovir probably more beneficial because it doesn't penetrate the topical, antivirals don't penetrate the intact cornea. And as I've said before, 400 milligrams of oral acyclovir twice a day for 1 year tends to reduce recurrence of herpes simplex keratitis by 50%. Episcleritis, very common self-limiting condition. You get nodular types or simple types. Mostly episcleritis are idiopathic. Only less than about 35% have a systemic vascular disorder, those patients. Rheumatoid arthritis, Crohn's, ulcerative colitis, SLE, psoriatic arthritis are the common conditions associated with episcleritis. So if patients have one, you can ask them if they've got any of those conditions. And it's generally causes a congestion of the episcleral plexus of the blood vessels, and the episclera tenons is infiltrated by inflammatory cells, and the sclera tends to be spared. So you get sectoral redness, sometimes with or without a nodule. And that's different to scleritis, where the sclera itself is quite violet in color. So that's an episcleritis. You can see the blood vessels are quite congested in that area. And if you put phenylephrine in, they will blanch. The conjunctival and episcleral vessels, but not the sclera. If you put 10% in, it blanches the episcleral, but not scleral vessels. Generally, if you leave it alone, it will resolve without any problems. If patients are reporting pain, you can give oral non-steroidal anti-inflammatories like ibuprofen. Just ask the patient to buy them over the counter. There's no evidence, in fact, that topical antivirals like Macular or Bromphanac or anything else make any difference. Topical steroids can help to settle it down, particularly if it's very uncomfortable, painful, which occasionally happens. But beware, because when you start, sometimes when you stop it, you get rebound inflammation when you stop the steroids. So tend to prefer not to give steroids if you can. And generally, these patients don't need any follow-up. So once you see them, you can tell them it's going to get better, but you don't need to come back unless it doesn't get better. So angle closure glaucoma, so an actual emergency, acute angle closure in brackets glaucoma. So I've done that because acute angle closure is actually the event, and the glaucoma is actually the outcome if it's left untreated, i.e. the optic nerve damage. So hopefully you will all know this. These patients present with severe pain, nausea, vomiting, rapid loss of vision. The pupil is fixed and mid-dilated. The cornea, as in this photograph, looks like ground glass and is very, very hazy. Often, angle closure is preceded by episodic symptoms of halos around lights or rainbows around lights or episodic stabbing pains in the eye. Risk factors for this are being hypermetropic, increasing age so that the lens gets bigger, and the lens tends to push the iris diaphragm forward. Women tend to get it more than men, and there are some racial predilection. So Southeast Asians, Chinese races tend to be much more commonly affected, and also Eskimos. Not that we see many Eskimos in Sussex or any part of the UK. There is also a hereditary risk factor. So the schematic diagram in this slide shows the iris bowing forward and blocking off the trabecular meshwork, giving the aqueous produced by the ciliary body nowhere to go. And the bottom schematic shows what happens when we do an iridotomy, where we laser a little hole in the iris, in the peripheral iris, and that allows the fluid somewhere to go to get into the trabecular meshwork and prevents attack of acute angle closure from happening. These are some photographs of rather mangled eyes following attacks of acute angle closure. The picture on the furthest right has got the biggest peripheral iridotomy I've ever seen. The middle photograph has got a lovely picture of glaucoma flecken. So that's what it looks like if you've never seen it before. And this is ischemic damage actually to the lens anterior capsule, which happens from angle closure. One thing to say about angle closure and the management of angle closure, I know we're running out of time, so I'll be brief, is that nowadays we tend to do many less peripheral iridotomies because there have been two huge trials recently, the Eagle study and the ZAP trial, which showed actually that YAG laser iridotomy has got limited value for patients. If patients in particular, if patients have got lens opacification, they're better off having the cataract taken out than having an iridotomy. But anyway, that's a talk for another day. Next, anterior uveitis, very, very common disease. Oh, sorry, one last thing with angle closure, as if it's not obvious to you already, but it is an emergency and you need to send that patient to A&E or to preferably to the eye doctor on call immediately. That's time is equals vision loss in these patients. So uveitis, part of many disease processes. It can be acute or chronic. It refers to inflammation of the anterior uvea, i.e. the iris or the ciliary body, and can be associated with systemic disease, but most often it's isolated. HLA-B27, which is associated with ankylosing spondylitis, is a risk factor for this disease. And the photograph at the bottom there on the right hand side shows what a mutton fat precipitates, and these are commonly found in patients with granulomatous uveitis. So that's things like sarcoid or TB tend to cause. So when you examine these patients, often they complain of a lot of pain. They describe the pain very, very classically, like it's being punched in the eye, a sort of throbbing pain, light sensitivity, very red eye, and the redness tends to be located particularly around the limbus. So it's sort of, you get the classical ciliary flush. So when you see these patients, check the visual acuity, examine the anterior chamber for cells, for keratoprecipitates, flare, which is like a sort of general haziness in the anterior chamber, sometimes a hypopion, and sometimes iris nodules. Synecchie, which is where the pupil gets stuck down to the iris, to the anterior lens behind it, and fibrin. Check the pressure in the eye, because sometimes these patients can have secondarily raised intraocular pressure. And in all cases, I would dilate these patients to make sure that there's no posterior segment involvement, no intermediate or posterior uveitis that's involved as well, because that can change the way these patients are managed in the long term. Managing anterior uveitis, the key is topical steroids. and a topical cycloplegic to get the pupil out of the way. I would tend to give patients Pred Forte 1%, probably hourly for the first couple of days, and then reduce it over a 6-week period. If it's very severe uveitis, you can consider giving a subconjunctival injection of a steroid or an orbital floor injection of Kenalog, and consider referring. I mean, for the independent prescribers of you who may be watching this, this is something that you can manage yourselves and the community quite well, and it's very, very helpful if you do so. Flashes and floaters, very, very common condition. Posterior vitreous detachment is the separation of the posterior vitreous cortex and the retina. The vitreous cortex is attached strongly at the vitreous base and around the ora serrata, but it's also attached around the optic disc margin, the macula, and around some of the retinal vessels, and some areas of the peripheral retina, like lattice. What happens in a posterior vitreous detachment is you get liquefaction of the vitreous, and then you get a rupture of the posterior hyaloid membrane. So the back of the vitreous splits open, and on the liquid within the vitreous bag then pours out between the vitreous and the retina and separates the vitreous from the retina. And the PVD becomes symptomatic when the fluid then separates the optic disc attachment, which then floats in front of the eye. And that's the classical vice ring that you see, the sort of C-shaped or round, often circular shaped thing that floats around in front of the retina. That's a nice OCT image which shows that sort of thin line at the top, which is the posterior hyaloid face, and that has split, and it's separated the posterior hyaloid face from the macula, but there is still an attachment at the optic nerve head, you can see there. So it's sort of not an incomplete posterior vitreous attachment. So why people get excited about PVDs is because if there is traction at sites of firm adhesion, these might result in a retinal tear, and that might then end up in a regmatogenous retinal detachment. PVDs, remember, are incredibly common. So more than 50% of all people over the age of 60 develop a PVD. And this tends to be manifest by a new onset of flashes of light, like lightning flashes in the corner of the eye, or floating objects floating around in front of their eye, like spiders or little dots. When you see these patients in your practice, or we see them in the hospital, you can examine them with an indirect ophthalmoscope and indent them, or you can just as well examine them on the slit lamp and use a superfield lens or a 3-mirror gonioscopic lens to look around the peripheral retina. But the important thing when you see these patients is to examine them fully with a well-dilated examination. So dilate the patients nicely and have a good look around. If there's a vitreous hemorrhage in the patient, so if there is blood floating around in the vitreous, then the patients have got about a 50 to 70% chance of there being a retinal tear. So these are nice pictures. So on the left-hand side, that looks like a retinal hole, actually. And it's probable that that thing to the right of it is the operculum of the hole. The picture on the left is a retinal tear where the base of the tear is still attached. There's also a shallow retinal detachment around it. Now, the retinal hole on the left-hand side, now that's something actually that probably doesn't need to be lasered. It probably doesn't need any treatment. And the reason for that is because there's no traction on that hole now. So there's nothing lifting the retina up and allowing the fluid to go in. So it's very likely that once a retinal hole has been discovered and there's no sign of a detachment, it's very unlikely that a detachment will ever occur. So patients who have a round retinal hole with a free-floating operculum, we tend not to do any retinopexy for these patients. You can reassure them and discharge them. But the retinal tears, yes, they need to be seen ASAP, really, not necessarily as an emergency same day, but they need to be seen, as soon as possible and lasered promptly to prevent a retinal detachment developing. And that's it, I think, that I had to say. I can see that there are some questions and answers in the
Hi,
box.
Cash. Can you hear me?
Hey, I can hear you, Ian. Hi.
So shall I read the questions to you this time?
Please, yeah.
Read them. So I'd just say an excellent talk. Thank you very much again. I know you've done this talk before, but it's always interesting to go through things again. So I've got quite a few questions for you. So the first question, if we see a patient at a funny age, like 65, with an OCT showing SRF and no macular hemorrhage, how do you decide whether it's CSR or AMD, as an OCTA and FFA are not available to us in practice?
So hello, Mo. So I would say that it's, for myself and Mr. Kashani, who've looked at these scans all the time, you can sometimes pick it up. Generally, with CSR, the fluid tends to be very subretinal, and the retina tends to be lifted up. There's often very little RPE defect, although not always. Sometimes you can have RPE defects with them. Often it's on the history. Often, if you look at the same eye or the fellow eye, there are signs of drusen or not drusen in patients with CSR. But I think the rule of thumb, though, is in the community, if you see a patient with subretinal fluid, I would refer them to the hospital eye service, irrespective, and then we could do an OCT in the hospital and determine. I must admit that we don't tend to do that many fluorescein angiograms nowadays, and it tends to be based on the history and the character. Often with wet AMD, the vision tends to deteriorate much more quickly, whereas with CSR, it tends to generally, not always, but generally be a bit more, the vision tends to be a bit more well spared for longer before it deteriorates. But I would probably refer in, but it's often sort of pattern recognition when we look at them to determine which one is which.
Do you get more of a positive shift with CSR than AMD? Do you get a positive hyperopic shift in the prescription?
Yeah, you do, because you tend to get a lot more fluid a lot more quickly, I think, in CSR. So you get a sort of a big bump underneath the retina, and it tends to be more, and tends to escalate much more quickly than wet AMDs do. And because the cellular function in the retina is quite good in a CSR patient, that you can, if you refract them and you correct the hypermetropic shift, then the vision tends to actually be relatively normal, funnily enough. Whereas with wet AMD patients, because the cells have been damaged a bit from atrophy and wearing out, they don't tend to do as well visually.
Mm. Can you stop sharing your screen so we can...
Oh yes, sorry, I will do that. But I'll also, yeah, that's fine. I was wondering if I just turn on my other light in here, because it's a bit dark. There we go. I don't know if that makes me any more visible than I was before.
Slightly, yeah. For the next question, what advice and treatment will you provide for a patient after receiving sort of foreign body removal?
Right. So, yeah, I would, advise a patient that it's going to be painful. It will be very, very sore and irritable and gritty for a few days. I mean, if you're a kind soul, which I know Atifa is, you might want to give them some cycloplegic to relieve the pain to an extent. Generally speaking, I would advise them that it will heal itself sort of within about 2 or 3 days and sort itself out. The epithelial defect will sort itself out by then, and it will just get better. You can give them topical, and we generally give them topical antibiotics, really prophylactically, to prevent any bacterial infection of the epithelial defect. And you could perhaps use that, for a few days or possibly up to a week. And if you give topical chloramphenicol ointment, then it tends to give a sort of lubricating effect as well, and makes it a bit less irritable and gritty. And the other thing I would say to them is wear your bloody goggles You know, don't do your angle grinding without your goggles on. That's the other thing to say.
I know you're reading the questions, but some of the questions are similar, so I am going to sort of
go for it.
do some of them. So, but the next question is, how long do we advise to do hot compressors before referring to the hospitalized service for removal?
So, I mean, the answer to this question really is a technical one, which is that the CCG, or the ICS, as we're now called, do not fund incision and curettage of chalazion until they've been present for 3 months. And that's a national thing, actually. So there's no point in referring a patient for incision and curettage of a chalazion unless it's been present for 3 months. We're not funded to treat them. I mean, if you want to send it to someone privately, they can do it. But actually, you know, a lot of these chalazion tend to resolve if the patients actually stick at it. If you interrogate these people, you'll find that none of them, you know, really stick to the regimen religiously. They tend to sort of do it for a day or two and then forget about it, and think, oh, it's not getting better, someone make it go away. But if, you know, occasionally, you know, where they have done it and it doesn't go away, then yes, you can do that.
You can, yeah.
Yeah, but 3 months is what I would say.
Perfect, thank you. For anterior uveitis patients, dilation, is it worth to use cyclopentalate instead of tropicamide?
Yes, definitely. And the reason, because the very simple reason is that cyclopentalate's half-life is about 12 to 20 hours, whereas tropicamide wears off after about 2 hours. So you really, and also you get a much better cycloplegia, which is where the pain is coming from. The pain is from ciliary muscle spasm, and the cycloplegia relieves that to a greater extent. And because the half-life is so much longer, it keeps the pupil dilated for longer and out of the way of all the inflammation, and relieves the pain. The only problem with cyclopentalate really is that it stings like mad when you put it in. So you just warn the patient that this will sting when you put it in, but once it's in, it will make the eye feel much better.
Oh, thank you. I never knew that. So thank you for that one.
All right.
PVDs with retinal hemorrhage. Do we refer those in?
Yes. And I would, because if they've got retinal hemorrhage, there's obviously some tractional component that's caused some avulsion. So you'd have a sort of high index of suspicion for a retinal tear. I think what I would say is that we ask people to look at Schaefer sign and to see whether it's positive or not. And you know, sounding delicate and indelicate, and I see a lot of referrals from around the whole patch that I work in, which is Kent and Sussex, of optometrists sending patients to services saying, you know, Schaefer positive, and then when you look at them, they're not Schaefer positive, definitely not. So it does make you think, you know, it's worth you guys reminding yourselves what it looks like. The thing that's annoying is I suspect sometimes people put Schaefer positive because they know that means we're going to see the patient. And actually that's not really great. It's not fair for a lot of patients, because it's then occupying, it's taking up a slot for someone who actually has a real problem. And I know people put it because they worry and they think, well, they don't feel confident about making that call, and they want, you know, someone else to make that call. But actually, I think genuinely you can make that call in the community, and you can give the patient appropriate advice and warning signs, signposting for what to look out for and come back. And you know, you don't have to automatically think, oh, it's that, I've got to send it to the hospital. You don't have to do that. You have got skills, and it will really help everyone out, including hospitalized services and the community services, if many more of these conditions were managed in the community. However, if you see something which gives you a high index of suspicion of a tear, like a hemorrhage or a vitreous hemorrhage, as I put on the talk, or Schaefer positive, but you can't see a break, yes, you definitely need to refer them in, because we need to have a look and either indent or use a 3-mirror to ensure that there's not an occult retinal tear.
So do you yourself have any videos or clips of Schaefer's positive sign that you could maybe put on the WhatsApp group? Or
I will try. I don't have myself, but I'm sure there are.
If you could find something to put on maybe the group that would show people, because I know myself, I have seen it a couple of times, but it's always one of those things, I think, until you've seen it, you're not really sure.
Yeah, I mean, I agree with you. It isn't, sometimes it isn't easy, and particularly it can be quite confusing in patients, for instance, who are pseudophakic and you know, they've had cataract surgery. Sometimes there is a little bit of pigmentary disturbance in the eye that then floats around in the anterior vitreous, and you think, well, is that Schaefer positive? That's one thing to say. And it can also be, the other thing to say is that sometimes what people report as Schaefer positive, when you then look at the patient, actually they've got intermediate uveitis, and those are actually inflammatory cells floating around. Yeah. So it's actually important to try and differentiate that, because actually if it is inflammatory cells, and that can be quite serious, there can be some actual major things. So there we are. You know, that's another thing to consider.
Well, if you can find a video or a clip,
I will. I'll have a look.
Really useful. So I'm going through these randomly. In a practice over the past 3 days, I've observed 4 patients over 60 with partial thickness macular hole. Is this a common condition?
Yeah, surprisingly, epiretinal membranes and macular, sort of lamellar macular holes are surprisingly common. Don't ask me what the incidence is. Off the top of my head, I don't know. But what I can say to you as a sort of anecdote is that I am very old, and I trained as an ophthalmologist before we had OCT scans, which were widespread. And so we used to look at these patients in clinic, and you could see the epiretinal membrane, you could see a pseudo hole, and so you'd see them and you'd take them much more seriously. But you see them very seldom, actually. Nowadays, because of the OCT scanners and because they're ubiquitous really everywhere, we're picking up very, very, very frequently. And the thing about lamellar macular holes is generally they're often asymptomatic. Patients are completely unaware of there being a problem or any problems with their vision. So consequently, you don't need to refer them unless they're reporting distortion or a drop in their visual acuity, because actually the vitreoretinal surgeons won't intervene unless there's a significant visual symptoms that make doing a vitrectomy and peel worthwhile.
I do like the bit where you said you're old. I'm older than you, so
I don't know about that yet. I'm not sure.
But the next sort of comment sort of goes on from what you said there. Do you want to see PVD for a follow-up in hospital if a patient is still symptomatic with flashes, but when we have dilated in practice and shows no tears or holes or tobacco dust due to the facility, due to the fact that they can take up to 6 weeks to fully occur and may create a tear in the next few weeks? And the fact that
no, I don't. In answer to the question, no, I don't want to see them, because they might. You're right. They might tear, but they might not, and they probably won't. And my advice would be is to signpost the patient with appropriate advice. So you know, if their symptoms change, if they get more floaters, more flashes of light, bits missing in their vision, to come back and either see yourselves again or to come to the hospital eye service again. You know, the point is, if you've seen them and there's not a tear or a break, and we see them and there's not a tear or a break, it's not going to change the management of that patient. It's if they develop a tear or a break, that's when we can actually do something about those patients. So no, I wouldn't advise you refer a patient with the PVD, just if they've got ongoing flashes. It doesn't matter. I would just advise them either to come back and see yourselves in a few weeks as a follow-up if you want to, but definitely to signpost the patient with advice about coming back to see you straight away if their symptoms change.
Cool, thank you very much. Is the removal of a rust ring a different process to removing the actual piece of metal?
Yes, depending on how you do it. And no, it can be exactly the same in answer and not answering Liam's question. So you can, most people in most hospital departments, it's probably actually more hygienic if you do use the same process, you just use the needle and the bevel of the needle facing you, and you just gently tease away at the ulcerated area until you get some of the rust off, and as much of the rust off as you can. And you'll never get it all off, but as long as you get most of it off, yes, it is the same. But there is also another way of doing it. I don't know if people do it anymore, but in the old days when I was a registrar, they used to have this thing called an algae brush, which was it's like a little battery operated pen-sized thing with a little fast spinning buffing thing on the end of it, and you would sort of hold it against the cornea. It would almost buff it out, the rust ring. But these things, I can't remember, the sterility of these algae brushes isn't brilliant, so I think some people were not that keen on using them. But yes, but you can do it with a needle, bevel of a needle, and just gently use the edge of the needle to just tease the rust off the edge of the rust ring.
I think a couple of people have not asked questions, but said it's such an interesting talk. Always good to hear with people's opinions. Thank you very much. Have to be cautious if we see HSK in a contact lens wearer. Have to suspect acanthamoeba until proven otherwise.
Yeah, that's a good point. That is indeed a good point. I mean, this is a very sort of brief overview of minor eye condition type things, really. But certainly that's a very good point. If you have contact lens wearers and they've got dendrite type lesions, you really have to be careful to exclude acanthamoeba, which is very difficult to pick up sometimes. And again, it's particularly if they've got sort of hazy satellite lesions from the dendrite, you might want to think about referring that as a matter of priority to the hospitalized service for them to have a look.
And someone in the questions has posted a video of a good link for Schaefer's sign, but
well, that's good.
But yeah,
thank you.
We won't be showing that. In the Wealden area, we are still posting to SEH rather than EDGH. I'm not sure that relates to with something. I'm not sure, but thanks.
I think maybe that's asking: are we signposting patients to Sussex Eye Hospital rather than Eastbourne? No, I mean I don't know why you would. I mean, other than
sorry, it's put on here regarding retinal tears or breaks.
Oh, I see. Okay, so if you've got no, I mean if it's a tear or a break, we can do a retinopexy in East Sussex in Eastbourne. It's only if they've actually detached. If they've detached, then they're better off going to Brighton and cut out the middleman, and we're the middleman in that circumstance. Although Brighton might not be in Brighton for much longer, I hear they might be in Southlands and Worthing. I've had a message from one of my incredibly esteemed local ophthalmology optometry colleagues.
Is that what Haag still sell that? Is that in response to that question?
No, it's something else. He sent me a text message saying that actually you can't refer Calazians actually for 6 months. It used to be 3 months, now it's 6 months. So you can't actually send a Calazian to hospital eye service until it's been there for 6 months.
But Haag still sells something, so I don't know what, because he hasn't.
Elian, what do Haag sell?
I wasn't going to say his name, but now you've said it. But
well, he's got his name there. I can see it. It says.
He has, but yes, I was trying to be.
Algae brush. It's the algae brush. Yeah. So yeah, no, I mean you can use an algae. It does work. It works very well, actually. I mean, it's in a way it's sort of incredibly satisfying thing to do because it sort of buffs out the rust ring quite nicely. But as I said, it's just a question of how you sterilize the algae brush, basically, that I always feel a bit sort of a bit worried about it. But I must admit that's completely anecdotal, and I don't think there've been loads of patients having keratitis, microbial keratitis following algae brush use, as far as I'm aware.
I think that is all the questions. So I would like to thank Mr. Kashif Qureshi for his talk tonight. It's been quite enlightening, and it's always good to hear again and remind yourselves of what we can treat in community and what we can't. I will be uploading this video onto YouTube in the next week or so, and I will be posting the CPD certificates out. I live in Eastbourne, and it is Eastbourne Air Display this weekend, so I will be quite busy this weekend, so it may be next week. The GOC say I have 10 days to send the certificates out. I always normally try and post them out within the next day or two, but I'll be honest, guys, I think it'll be next week the certificates go out. So just to save you emailing me to say I've not received my certificate yet, I'll probably do it next week, just so you know. But I'd like to thank you all again for joining us tonight, and apologies again for the slight delay to the start due to technical issues with IT and internet and computers, but we got there in the end. So thank you again for joining us and being patient with us. And thank you again, Mr. Qureshi, for that talk tonight.
Well, thank you, Ian, for hosting it, as usual, and for putting up with my technical incompetence. Just as a final word to all my optometry colleagues out there, thank you for all your kind help in the community, and long may we continue managing these things together and be able to manage more things in the community. That's what my aim is.
Well said. Thank you all for joining us again tonight, and watch out on the WhatsApp group for the next talk, which I'll be trying to organise in the next week or two, and hope to see you all again soon. Thank you all very much.
Bye.
Bye-bye.
Bye.